America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone. Hi, everybody, and welcome to another episode of Main Street Matters, America's small business megaphone. I'm Elaine Parker with the Job Creators Network. Healthcare is supposed to heal people, but for many small businesses and families, it's become one of the biggest threats to their financial security. My guest today is Dr. Firouz Daneshgari, a surgeon who spent 3 decades inside some of America's most powerful hospital systems, including Cleveland Clinic and the University Hospitals of Cleveland. After seeing firsthand how financial incentives outweighed patient outcomes, he became a whistleblower and founded Bowtie Health Guardianship, a model designed to protect patients, cut waste, and put proactive care back at the center of medicine. He's joining us to explain why healthcare is broken, who has heard it the most, and what a better system could look like for small businesses and families. Dr. Firouz, thanks so much for joining us.
Thank you, Elaine. It's a privilege and honor to be here, and thank you for having me, and thanks to other colleagues, Tom and Freedom Chamber members. As you mentioned, I was my journey of my career. I started as an academician, as a surgeon scientist. Soon became one of the most known surgeon scientists in my own field, until I reached to the peak of my academic career when I was the chairman of a large clinical enterprise, about $3 billion a year revenue at that point. And because of the success I've had through my career, they asked me to serve on the board of that enterprise. And that is where my eyes opened to the dysfunctionality of the healthcare system. And I, because of my scientific curiosity, I took upon myself to go and figure out why we have this problem, why the healthcare is the number one discussion about in many circumstances, in many cases, from the White House to the Congress to every night family dinner.
What is the main cost driver, Dr. Firouz?
The problem is, we have a 5.6, as of last year, we spent $5.6 trillion on healthcare. And if I have to give you a level, is our entire defense budget is less than $1 trillion, is about $990 billion. We spend less than about 1/5 of what we spend on the healthcare and the defense, and thankfully, no one dares to touch us. We spend 5 times more than that on our healthcare when we're producing one of the more problematic outcomes. Our people are not getting healthier. The costs continue to go up. And despite the title of it, the Affordable Care Act, actually that made the healthcare costs more unaffordable. The main driver of the cost, answering your question, is over the past 67 years, after World War II, after the employers became the sponsor of the healthcare for about 2/3 of Americans, and in 65, the federal government through the Medicare became a sponsor of 1/3 for Americans, we have adopted the sick care over healthcare. And this process has moved from the hospitals being the charity houses of the late 19th century to financial institutions that basically give priority to revenue over the health outcomes. This has created what we call the healthcare really a sick care. We have 5,000 hospitals in the US who have become financial institutions, and they compete on the margin, not based on the health outcomes that they generate. And because of that, because of the details of how this system has evolved, that people basically go to hospitals and they sign a white sheet of paper. They say, I'm going to pay everything you charge me. The hospital have become addicted to generating at least 50% of the waste. Waste meaning in terms of the care delivery, they do things that do not add to our health outcomes. Waste in terms of the payment methodology, the billing fiasco that we have here, and overall, based on independent research by the Institute of Medicine, Johns Hopkins, many other validated elements, more than half of what we do, half of what we spend is a waste, does not create health outcome for our population, and just keeps adding to the cost. And this concept of the more is better, a philosophy that the hospitals, these 5,000 financial institutions have created, incentivizes the unnecessary services. And this process, if I take you through the historical part, the health insurance as an entity was born during the World War II. The details of it I've written in the book that was on the presentation in the front page. And the health insurance was born. And because during the war there was a wage freeze, the IRS approved the cost of health insurance as a cost reduction or cost deductible for employers. Therefore, the employer sponsor insurance took off. President Truman took a single payer proposal to Congress in 1959, but was defeated by the hospitals. And in 65, the leftover of single payer was created as the Medicare, Medicaid to cover basically elderly, poor, and disabled. So ever since, the hospitals have taken the lead in delivering the care, but not based on efficiency and the outcome, but based on the volume. So we basically subsidize the cost of this in an efficient system on a cost plus basis. And this waste, again, is generating in terms of the procedures, in terms of the things that the hospitals are doing without any improvement of the outcomes. And they have sustained this system, this hospital, what I call the hospital-based sick care system, has been able to grow and to do this and created three major misalignments. The first one is, and I'll take you through a quick story, hospitals realizing that they need to make more money in 1960s and 70s, they started hiring the specialists, surgeons like me, because the surgeons, they do the surgery, they make the money. If you remember, before 1960s, 60s, 70s, the majority of the physicians were independent. That's why actually the Blue Shield and the Blue Cross was labeled. Blue Shield is for the hospital coverage, Blue Cross is for coverage of the doctors. When the Medicare was born, Part A is to cover the hospital expenses, Part B is to cover the physician's expenses. But the hospital started hiring the specialists in 70s and 80s. And then in 90s, they realized in order to have a feeder into the specialists, they need to hire the primary cares. So in early 2000, all the hospitals in the major markets, they went and they started hiring the primary care physicians. And this is how my eyes opened to this whole process. As a part of the board member of this enterprise, my job was to go and identify and hire primary care physicians. I will go and identify a group that are in the neighborhood, take them out to dinner, tell them, here, we would like to hire you. These are your salaries and your bonuses. About 3 months later, I'll show up with a bunch of bean counters and I'll say, guys, seeing 20 patients a day is not going to make your salaries. And they say, what do we do? I say, well, now we control your schedule. We're going to increase the number of appointments to 30, 40, 50, 60. My target was 90 because I had heard somewhere in Memphis could see 90 patients a day. And physicians are shocked. They say, how can we take care of patients if we have to see this many patients? I said, now you're a part of the big system. You don't have to spend a lot of time with them. As soon as a person comes in with AYZ symptoms, don't just treat them with antibiotics, send them home. Send them to me as a urologist. If someone comes in with the prostatitis, with the blood in the urine, I'll do cystoscopy, I'll do CT urogram, I'll do XYZ, and I'll take a good care of them. But in the background, I knew I was protecting my clinical volume because every department, every physician was incentivized. Their salary and their bonuses depends on how much volume they generate. Therefore, the first misalignments And in majority of the markets now, after this 30 years of consolidation, over 80% of all the physicians are employed by a hospital or a corporation. The second misalignment is that the third party entered into the relationship between the doctor and the patient. This is a $5 trillion industry that's been built based on one relationship, the relationship that has been protected by the Hippocratic Oath and the trust. So the insurance companies, including Medicaid, they came in middle of this relationship, now deciding what prices the providers should be paid, and what services the patients could receive. So they have this intermediation of the third party has dislodged the patient as the consumer from its role as a customer. So therefore, the customer, unlike any other industry, doesn't, when it goes to basically a seller of a service, in this case a provider, a doctor, or hospital, doesn't ask how much this is going to cost me and what are your results. You know, when we go and buy a car, when we go and buy a house, when we go buy anything, we have that interaction of exchange of information. Depends on the quality and the price, we decide what to buy and what not to buy. That interaction doesn't exist. The insurance companies, they decide basically where you can go, which doctors you can see in network and out of network, and what cost those doctors are going to be paid.
Dr. Firouz, that's the foggy world of the consumers, the patients. They don't know the
Right.
cost of their health care, and they only are incentivized in two ways. The only thing they care about, they're not incentivized in any way. The only thing they care about is what is my monthly premium and what is my copay. That's it. They don't care how much the cost of the procedure or the medicine or the doctor visit is. It's just how much does it cost me? And until you bring them into that relationship of a purchaser, a consumer relationship, they're not in that consumer relationship right now. That is what's so frustrating about our current system is we don't know the cost. We're not incentivized to care what the cost is. We only care what we're paying.
You're absolutely correct, Lane. That's why I fully support President Trump's initiatives to give the subsidies to the patient through the HSA and FSA accounts rather than to the bowels of the insurance companies. So as you're saying, whoever controls the money controls basically the decision. And
Right.
the process of what I call a deconstruction of the sick care and reconstruction of healthcare, frankly, is not that complicated, Elaine. And thankfully, again, this current administration, through this term and the previous term, has unleashed some initiatives that would support this movement from a basically consumer who is not involved in that process to a customer who is involved. Because over 80+%, this number is in one of the President Trump's executive orders, over 80% of the healthcare services are shoppable. It's just a matter of who controls the money. Going back to the problem, I think everyone agrees that there's a problem. Again, the very first slide I showed you was the front page of U.S. News, and February of 2020, right in the beginning of the COVID pandemic, that over 92% of the Americans believe that our system is sick. So the question is, and in the beginning, before we came on live, you asked me what are the solutions. The solution is first is to separate the primary care from the existing system. Primary care is, if I make a example, if you think about, let's say 100 years ago, if you remember that Rockwell drawing that the doctor is giving an injection to the little boy in the office, most Americans have seen that. That doctor had two functions. One was a caregiver. As a family doctor, will take care of your pain and infections and deliver the baby and pull out your teeth, but also had another function, and that was the guardian. They were the guardian of your health. If they could not provide you a service, they will go and seek out those services. If they admitted you to a hospital, they come and visit you in the hospital. When was the last time any of us experienced that our primary care, if we got admitted to the hospital, they come and basically visit with us?
Right.
That role of the caregiver and the guardianship, because of this because of what I explained, that the doctors have become the employees of the hospital. So they have because of the system, they have changed their jobs from being the guardian of the health of their patients to the protectors of the revenue and financial interest of their employers. And the finances incentives works for doctors as well as for every other human being. But if we separate the primary care, so primary care is called the direct primary care concept. So rather than the primary care working for a hospital system, now by a subscription model works for you. So you go, whether you have a high deductible health plan or you participate in it, you go and pay X number of dollars. In our prices are $65. You pay $65 a month, ranges between 65 to 100, and basically now the primary care works for you.
Like a gym membership, right? You're describing basically. So that's what I have, Dr. Firouz. I have a direct primary care doctor. I pay a set amount per month. I have a family. I have my daughters on it with me. I have a bit of a hybrid because I also have employer provided insurance. And for me, I wanted the relationship and my direct primary care physician to be able to direct my health care and be very involved in those decisions with me. And that's why I did it. And she has been wonderful and instrumental in ensuring that I got the tests that I needed in the time frame I needed them. And in a specific case, she actually probably saved my life. And so I love the system. I promote the system as much as I can and try to help people understand how much better it is to be in control like that. And it's a set price. I pay one set price. I can message her on her telehealth system anytime. If I have a question, if I have a concern, I can always get in to see her. And of course, I do an annual visit with her to meet with her. Last year, it was a 2-hour visit. 2 hours we sat there and discussed everything about my health.
I'm delighted to hear your experience. This is exactly you transfer the message much clearer than I can, and that is how the first step. However, in order to make this a nationwide solution that could be affordable by everyone, the primary care is the trust builder, is the relationship builder. It takes care of 60, 70, 80% of the needs we have. However, the primary care in its existing situation cannot impact the cost because the more than 90% of the cost relates to the specialty care. And that is where the concept of the guardianship was born, is how can we take this relationship that you built, you explained, we can basically, number one, expand the scope of the primary care. So primary care is not just a referral machine. So if you have diabetes, if you have hypertension, if you have any other chronic conditions, the primary care can take care of that because, again, this is now they're your agent. The second part of it is that role of the guardian, that primary care who knows you now the best. When it comes that you have a hip pain or you have a knee pain or your children have XYZ needs, they are the guardian. They help you to choose the proper care you need. They make sure that you don't basically go into the bowels of the hospital system and do all those unnecessary procedures and so forth. So you get the needed care. The second part of the needed care is you pay the fair price. And that is why, again, the concept of a cash pay, upfront pay comes in. Again, thanks to President Trump, now all the providers must accept the cash pay. And that eliminates the waste from the billing process because significant fraud and abuse goes under the billing process. Many of your listeners, probably all of us have experienced. You go to a service, to a doctor procedure and so forth. They send you 30 days later, they send you this paper. They say, this is not a bill. Looks like a bill, but it's not a bill. Right. And then 30 days later, you say, oh, this is part that the insurance paid. This is the part is your responsibility. And that responsibility of the consumer has turned into 50 million Americans have over $140 billion in medical debt. The medical debt has become number one cause of personal bankruptcies. So direct pay to the specialist is the way we call it the upfront cash pay is the next step on top of the primary care subscription model to eliminate the waste.
So it's
Because
like
one thing
direct
I didn't say
specialty
in the
care.
beginning, yeah, I
It's
didn't
like
say in the
direct
beginning,
specialty
this
care,
50,
right?
yes, yes. The 50% of the waste is not just a matter of economical waste. Everything we do in medicine has side effect, has complications. It's just a matter of balancing a risk and benefit ratio that has to be done very diligently with the utmost care. And frankly, in the current system, because the incentives are such that you have to do more and more and more to make your salary, they do not spend the time. The average time an specialist spends with a patient is about 5 to 7 minutes in this country. As you explained in your experience, when you change the incentives, the payment model, the doctor will spend an hour with you, 2 hours with you. The doctor will turn back to their original mission, and that is a problem solving, not basically running on the treadmill to see more and do more and more, so forth. So those are the really two components. One is a subscription model. One is this guardianship concept to help you to make the informed decision. And that is the concept of the solution we have proposed as a health guardianship. And going one step further, before the COVID, we said we think that the future of the technology and the fact that the majority of exchange between the doctor and the patient is the exchange of information, and the easiest way, the most economical way to collect information and exchange it is digitize it. So we created this direct primary care that is virtual. So you can deliver that to any corner of the country. So all the shortages in the rural areas and the areas where the providers are not available goes away. And currently we are delivering this virtual direct primary care to about 70,000 members in all the 50 states, exactly the same quality, the same concept that you presented. We spend as much time as the member needs it. As you could see, I deliberately use the term member. I don't tell them patients because my dream is, or my promise is, we want our members never become a patient. We all are consumers of healthcare. We need healthcare needs, but I'm hoping by this preventive measure, ease of access, our members never become a patient.
So let me sort of break this down for our listeners. So you're taking the direct care primary model, which is the subscription base we discussed that I have for my primary care physician. It's a monthly membership fee. And you're pairing it with a major this is going to be a poor term in our world, but like a major medical or a catastrophic plan to pay for the unforeseen. You're right. In the beginning, you said you can shop for these things. You can shop for the best root canal. You can shop for, the best price, the best quality. You can shop for that. You can shop for planned events. You can shop for an MRI. You can shop for an X-ray. Those are things that are non-emergent, but you can't shop for your next heart attack or your cancer diagnosis. So when you pair that direct primary care model with your guardianship, what does that look like? What is that? What is that plan, and how does it work?
Sure. Yeah, you're absolutely correct. So number one, again, I call it the guardianship because it's more than primary care. The primary care concept is an expanded, so a significant part of the specialty needs of a consumer could be handled by primary care. Again, the way it used to be, and with the new access to the information and data, it's just a matter of that subscription model protects the time of the time of the physician who needs to spend time with their member, with their patient. The next step of other than basically delivering the care is that the guardianship concept. What you're referring to goes back to basically the insurance part of it. How could we basically have a catastrophic coverage or any kind of insurance in the case of unforeseen events, basically can cover the cost? And we deliver that through a product with a partner we have called Detego Health that can provide basically coverage, provides that coverage. So our product now, our health guardianship, is embedded or can be embedded for people who don't have the catastrophic coverage within a basically insurance product that will cover that insurance. For example, in your case, you said you do have the direct primary care subscription, but you do have an insurance on top of that.
Mhm.
So in that case, we basically have consolidated into one product. Currently, we can deliver that consolidated one-stop shop product to all the employers, up to about one employee. As you know, the majority of the employers in the U.S. are less than 50, 60. And we deliver the benefits, the quality and savings of the health guardianship, plus that the coverage for insurance part of it through a product.
So it's still essentially employer provided insurance. And I'm not locked on an employer provided insurance myself. But I know most of Americans feel better when they have employer provided insurance because it's what they know. And so they
Yes.
want simplicity. They don't want complication. They want to be able to look at a card, look at a list, see what doctors they can go to, find the doctor they like, and go to that doctor. They want it simple. They don't want to get into the
Yes. Yeah.
the making of the sausage when it comes to how do I get my
That's
health
right.
care. They just want to show up and get it. So
Yeah.
so you have one plan that allows people to go to their direct primary care health provider, and that direct primary health care provider does exactly what they're used to seeing in a PPO, traditional PPO, or an HMO, where the healthcare provider is managing your healthcare with you and making those decisions, and then guiding you through specialists if you've got a more complicated
Yep.
issue.
Yep.
If you
And
have an emergent care, you're going to an ER just like any other
correct.
person if you
Yeah.
have something that is major. From what I have read about the plan, your subscription list of doctors is exactly the same list that the major PPOs would provide.
Correct. Actually, I do not use the term PPO because we say, because of the power of cash payment, we say you can go wherever you choose to, wherever we find the highest quality person that can take care of you, because we offer them cash. And again, by law, all the provider needs to accept the cash.
But the patient, the consumer, me, the person showing up
Yeah,
for my
yeah.
appointment, I'm not paying the cash. It's actually
No, no,
you.
no, 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 no.
It's
That
actually
comes
the
out of
plan.
your insurance pool. Yes, yes,
Okay.
yes.
Okay.
That's why
Yeah. Yeah.
I'm looking for a better term to replace the cash. You basically paying upfront, or we pay on your behalf upfront, but
Okay.
that gives you eliminates the concept of the network, because the network is another source of the waste. Again, the insurance companies have created a network to protect some of their margins. We say you should go to where the best place is. I'll give you one quick example. We had a member who had a tumor in his adrenal gland, and because of my background at one of the systems here, Cleveland Clinic, we went there and we said, how much would it cost to do this? They said it will cost 110,000. We had a contractual price, network price with them that would be $75,000, and then we said, what if we pay cash at the day of the surgery? They said, we'll take $45,000. And our guardianship team went online. They said the person who had done the most adrenalectomies during his fellowship at Cleveland Clinic now lives in Florida. We contacted him. I said, how much would you accept for the cash pay for adrenalectomy? He said $25,000. The employer bought the ticket. This is an elective procedure. It was not an emergency. The employee flew to Florida, got his surgery done by one of the best experts in the world, and the employer saved $85,000. So that is the power of the guardianship, in terms of the purchasing, in terms of the network or the access.
So you could use the tagline, "Cash is king in our world."
That's well. It's not the cash. Again, the term is we pay upfront, so we don't wait for that billing process. Because as a part of, as you said, I was a whistleblower. As a part of my work in the system, I learned there is a significant upcoding that goes on behind behind this billing process, and that is unfortunate. But that is how I will tell you one example, Elaine, because these are some of the emotional impact of this. Examples really made me to decide to change the direction of my career from a very highly ranked academicians to come and build something that I'm proud of. And as you seen from my name, I'm an immigrant, and I say some immigrants are more American than Americans because they have seen the difference. I believe that we have the best doctors in the world. We have the best technology. All we have to do is revise, deconstruct some of the element of the sick care, reconstruct the healthcare. Frankly, this will create the next biggest chapter of value and wealth generation for our beautiful country. So one day I had built a clinic. I was seeing the patients. So I saw someone is putting a plaque on the door that this clinic is an extension of XY hospital. And I said, wow, this is a very long extension cord because we are 10 miles away from the hospital. The guy laughed. I said, why you do this? Why you put in this plaque? He said, well, from now on, we can charge facility fee. I said, what is the facility fee? He says the Medicare allows us to charge for facility fees. The clinic is a part of the hospital. I said, so how much is the facility fee? He said about $750 for an outpatient visit by a specialist. I said, how much is my fee that I charge for I didn't notice. He said, well, your fee is about $250. The facility fee is $750. I said, so if I understand this correctly, by simply putting this plaque, assigning the clinic as an extension of a hospital, the patient who saw me yesterday would pay $250, and the same patient, if he comes and sees me tomorrow, will pay $1,000? He said, yup. I said, this is a white-collar criminal act. What do you mean, yup? He said, that is what the insurance companies allows us, Medicare allows us. So this goes back to the bottom line notion that any rules that the government thinks that they create to create efficiency, the system finds basically the turnaround time, and that's why the system is getting more and more expensive. The cost of healthcare for a family of four, Elaine, in 2010, when Affordable Care Act got enacted, was $18,000. That cost now is over $35,000. Within the last 12, 14 years, it has doubled up. So the point of this is that and as you could see, the government can afford it now. The private market can afford it. We are spending 2 to 3 times more than the rest of the world. We are spending now close to $14,000 per capita for the healthcare. The European counterpart, Japanese, they're spending 4,000 to 6,000 per capita.
So
and this can't just can't continue.
Let me ask you a question as we wind down in our last few minutes. President Trump has proposed giving the Obamacare subsidies directly to Americans, to patients, to the consumers through HSAs, which I think is a fantastic idea. It's the same subsidy. It's going to the same people who are going to use the insurance, and they're going to go and buy insurance themselves that they like, that works for their family, and there is their choice. Why is the left so against allowing them to purchase their own insurance? It's the same tax subsidies, same tax subsidy that's going to go into an account that they get to manage and spend.
Yeah. I'm an apolitical person, but as you've heard already, I definitely support the initiatives for a free market. In my opinion, the consumers, when they have the money in their own pocket, they're the best purchasers, they're best customers. The only thing I can think of answering your question is they don't understand the mechanics of the healthcare. In the good case scenario, in a bad case scenario, there are a lot of insurance and hospital lobbying that's filling up their campaigns. But again, I'm an apolitical person. As a scientist,
you talk to both sides, Dr. Firouz? Do you talk to the Democrats?
I do.
And do you try to educate them on what it would mean to allow patients to have these subsidies and how it would change the relationship?
Yeah.
Okay.
Yeah, I do. I tell them it's like we have a gas guzzler, we have a wasteful system, and your proposal is to make it equal. Let's go and buy a gas guzzler for everyone. The fundamental problem is not who is basically whether it's the government is paying for this or individuals. The fundamental thing, we need to create an efficiency in the system, and the model that we described briefly over the past 30 minutes is the model to create efficiency and improve the quality and the experience as you explained yourself. But let me tell you, if I have 1 minute, let me put this bow tie concept. The reason we call this a bow tie, as other than that, I wear bow tie, is really a risk mitigation concept. The concept is we all are at risk for health hazards. We are consumers. If we are born and we are at risk for diabetes, cardiovascular, cancer, and so forth. We have two ways of handling this. One is we wait for the symptoms for that chest pain to come in, and then we deal with consequences. Or we say, no, the risks are actual, and the health event risks are actual wherever we are in their life. We can basically look at the risk elements to predict and prevent these health events. We can predict the obesity and diabetes and prevent them. We can predict the cardiovascular. The chronic conditions, the top four chronic conditions, cardiovascular, obesity, diabetes, and musculoskeletal, we have spent 75% of that $5.6 trillion on this. And all of those, scientifically, that I know this, they're predictable. Is the reason is we are not doing is because we have 5,000 hospitals who make money from this side of the bow tie. And our job in bow tie is to create a model where we basically can shift the approach through that primary care, through the health mitigation and wellness component to here to reduce the chances of the health event for all Americans. And frankly, hopefully, if I get the chance to go in front of the president, I will tell him that we have a model for creating a absolutely affordable healthcare for every Americans to the point that he can claim we can have a universal coverage in this country. Very, very affordable.
It is. And if I might add, we're so proud at Freedom Chamber to have Dr. Daneshgari, Dr. Firouz as our healthcare advisor. And I worked with Dr. Firouz and Datego Health in putting together the solution for our chamber members. And so it's already available. We don't have to wait for congressional approval. And we have companies taking advantage of it. And I will tell you, Elaine, you brought up a very good point. Why do we still rely on the employer model? And I think a lot of it is it's a mechanism that seems to have worked pretty well until the government really got involved. And so we retain the employer solution with the guardianship plan, only you're getting from point A to point B in a hybrid faster on a sunnier day with better music. So it's still a employer plan, but the employees are treated like individual members, like individual patients. And I know you had Chuck on from our organization a couple of weeks ago where he spoke specifically and personally to their experience. Dr. Firouz, the bow tie team is incredible. How they not only do they work with addressing the issue at hand, but then take the further step in navigating and bringing the person to the right caregiver and making sure that they get the right labs, making sure that they get seeing the right specialist, that they're getting the right follow-up. It's a great way forward. In a way, it's almost back to the future, isn't it, Dr. Firouz? Going back to the old way of delivering service.
It is. With the 21st century tools, I propose that we all are capable of living to 100 without chronic conditions. If we take this right approach, and Elaine, we did this in the past century. The past century, number one killer, the health risk was the infectious diseases. Within 2 or 3 decades, we realized if we come and basically do some preventive measures, wash hands, clean water, food, and so forth, we eliminated the infectious disease as the number one killer. We can do the same target on the chronic conditions. And on the cardiovascular, obesity, diabetes. And as you witnessed, President Trump, when he issued Secretary Kennedy's assignment, said your job is to reduce the chronic conditions. And I think this model of the health guardianship, as Tom says, is a bird in hand. We have proven track record that not only we provide the outstanding access and the care at the very affordable price and so forth, it has the highest chance to reduce the chronic conditions impact simply by adopting this concept. I make a quick example. I say 124 years ago, before the first flight took place in 1903, flying was a dream for human beings. We used to put wings on our hand, but within 123 years, we have created the safest mode of transportations. The rate of killing by the cars and animals on the ground are much higher than the mortality than airline. We
Right.
can, by the end of this decade, frankly, or the next decade, we can create a model that is affordable, available anywhere you are, rural areas and so forth. The highest quality in terms of the experience, as Tom said, Back to the Future, and eliminate the chronic conditions consistently and progressively.
Well, Dr. Firouz, I think you've done a great job at explaining a very complicated issue. And again, as patients, as consumers of healthcare, they just want to know that they can see a doctor when they need to see a doctor and that they can afford to see a doctor every month when they have to pay their premiums, and that's what's most important to the consumer. But you've taken it a step further and really helped to explain it to how people can not only afford it, but small business owners and business owners themselves can afford it. So I appreciate that. I'm a huge supporter of this system. I'm living the system. I sought the system out because I believe that it works better. And that we can move to this kind of system and move to having the best healthcare in the world as a result. But we are going down the wrong path right now for sure. So I appreciate you speaking out and sharing this. Where can people go to find out how to get more information on this and how to actually become a member? Or do you call them a member or subscriber?
Members, right? Our website is bowtiemedical.com, so they can reach out. And my phone number and my email is there. But bowtiemedical.com is available to anyone, any employer, frankly, or HR person or CFO, or frankly the associations. You mentioned the associations of the healthcare. Again, thanks to the administration, now we can bring actually a group of employers or the associations like Job Creators Network, like the Freedom Chamber, and create an association of healthcare and basically provide this guardianship with the insurance package to the associations. So associations comes with the benefit of the healthcare, affordable, high quality, affordable healthcare, and through that, frankly, add a significant value to their membership. So this is right up our alley. This is doable. We don't again need to go to the Congress. We can do this within 90 days. We can set up an association of healthcare for groups like JCN Freedom Chamber, which we are in the discussion, or any associations, the restaurant associations and so forth, because a lot of part-time people do not get the healthcare coverage simply because of the cost. The small employers cannot afford it. But through the membership on an association, an affordable program could be extended to everyone.
And you have Bowtie Medical has a great partnership with Freedom Chamber. Tom Sadaka, who is joining us as part of the broadcast as well. Tom, can you tell everybody where they can go to join Freedom Chamber as well?
Yeah, absolutely. Freedomchamber.net. Freedomchamber.net is where you go. You can get information on the healthcare as well as a myriad of other benefits that we offer. Also, networking opportunities. We're growing our membership. We're targeting 100,000 companies to be inside the chamber inside of 5 years, uniting so that we have JCN carrying our flag to Washington, D.C. to let them know, keep an eye on the small business and protect them and let them grow. And the health benefits, working with Dr. Firouz and Richard over at Datego to have this offer now to our employers is phenomenal, and it's ready to go. It's turnkey for members. They can go to freedomchamber.net, sign up. It's a modest $399 a year for being a chamber, what we now call a chamber client.
Wonderful. Well, I want to thank you both for taking the time to join us on Main Street Matters, America's small business megaphone. And thank you all for taking the time to join in. Main Street Matters is part of the Salem Podcast Network. New episodes debut every Wednesday and Friday. You can subscribe to the show wherever you get your podcast from, and we will be back soon with another episode. Bye for now.